So this is a 79-year-old male who complains of increasing bouts of fatigue and intermittent moderate to severe abdominal pain, has a pretty significant past medical history of type 2 diabetes that's controlled with insulin. Patient is obese with a sedentary lifestyle, has a history of gastric ulcers that were treated with H. pylori but not currently bleeding at this time. Also former heavy alcohol use and cigarette use, 20-year smoking history, but quit about 10 years ago. And CLL was diagnosed about 2 years ago. Relatively asymptomatic at the time, patient was managed with active observation. Patient has a little bit of renal dysfunction, likely related to some of the medical issues with a creatinine clearance of 64 milliliters per minute. So physical exam reveals bulky adenopathy in the cervical and axillary chains, as well as inguinal lymphadenopathy, causing some symptoms to the patient. And then a CT image and chest x-ray are performed, which show a large right pleural effusion, as well as multi-station bulky lymphadenopathy, hepatomegaly, and splenomegaly, and let's say the spleen is approximately 18 centimeters in size. So this patient has a little bit of an unusual presentation that they're presenting with a symptomatic pleural effusion, and the patient undergoes thoracentesis, and pleural fluid analysis is positive for leukemic cells. So just out of curiosity, is this something you see in the lab very often, or is this an infrequent occurrence?
We do see this, that you do develop leukemia that's found within the pleural fluid. That is a common thing.
I want to raise a precaution is that most of the time, patient who has body fluid analysis, actually virtually all CLL patients, if they have active disease, when you do a body fluid analysis, you're almost always going to be able to find CLL there. But what I used to tell whether this is actually not really a pathologic, kind of a malignant effusion versus just CLL cells being there as an innocent bystander because they're
Passengers
everywhere.
is another term,
yeah,
right?
exactly.
Yeah.
Is that I look at the percentage of the CLL. So if you see in your body fluid is primarily T cells, and CLL cells are just a small proportion, I think that's probably not pathologic.
Yeah,
It's
I
just
would
an innocent
totally agree
bystander.
with that.
Yeah. But if they're accounting for the majority of the cells, then you might think otherwise. I would say it's very rare. I've seen very rarely true cases of malignant effusion from CLL.
Non-transformed CLL, yeah.
Correct.
Totally agree with you. I've seen it, but it's one case a year. So this is a very unusual case. What's your experience?
No, so at the recently concluded IWCLL meeting, we had data on pleural effusions as the presentation or the presenting feature of CLL, and patients needing thoracentesis to actually establish a diagnosis of CLL. And of our database, we identified less than 20 patients who actually had that presentation. So it's extremely rare. And like you mentioned, you have to be very careful because like this patient, our patients have multiple comorbidities. They have heart failure, they have pneumonia, other reasons to have pleural effusion. And before attributing the effusion to CLL, we have to be careful to exclude alternative etiologies.
It's a little bit off topic, but I would say the most difficult and dangerous fluid analysis that leads to wrong medical decision-making is the CSF, where there are so many reasons to have these bystanders or passengers present, and almost never, in fact, maybe never, is it really due to malignant infiltration of the CSF as a cause for the presence of those cells.
Right, and this is in stark contrast to, for example, if you see large cell lymphoma, then it is diagnostic of CNS involvement or even involvement of the pleural space, because it would be unlikely that you would see large cells in spaces where, like pleural fluid, for example, or CSF. So I think it is important to recognize that it's different depending on what kind of histology you find in these fluid analyses.
All right, well, we digress a little bit from the case, but I think that's really interesting conversation. So the patient does have a CBC performed at this time. The white blood cell count is 83,000, predominantly lymphocytes. The hemoglobin is 9.1. I guess we should have said this earlier, but when thinking about these hemoglobins, we probably need an MCV to really try to decide if this is disease-related or iron deficiency, for example, or some other cause, or nutritional deficiency. Platelets are 108,000, neutrophils are 1,700, LDH is 250, and beta-2 microglobulin is markedly elevated at 8.9. So this patient has molecular testing, including FISH with no abnormalities, and is IGHV unmutated. Any comments there in terms of the workup that's been performed?
So the workup here, although the FISH is negative, FISH can sometimes be like overemphasized. I think you really need to do a karyotype on top of this because FISH is a very targeted entity, whereas a karyotype, you may find other alterations which may change your prognosis, which you won't find on the FISH if it is negative.
Okay, you just opened a box for the conversation here. So, this patient did have a bone marrow, but I didn't mention that those were tests, whether they came from bone marrow or peripheral blood. So karyotype, you get a peripheral blood sample sent to you in the lab. Do you go ahead and perform it? How do you do it? Do you stimulate? Do you insist on a marrow sample? What's the yield from peripheral blood? How do we do this?
So peripheral blood, we typically, routinely, we do not do a karyotype on that unless specifically asked.
You need a marrow then.
We would
Okay.
typically want the marrow to do that.
And then, we'll probably get a couple different answers here, but from a pathologist perspective, we call these things complex. That has certain meaning to it. What does it mean to you? What does it mean to all of us?
So the pathologic definition is whenever you have greater than 3 abnormalities, that is considered complex karyotype.
Now, we just, interestingly had a paper that we submitted where all of a sudden the definition changed last week and it was now 5 or more abnormalities. So I'm just curious, in our practices, are we doing 3 or 5, and where do we feel the data are?
So I think we do CPG stimulated karyotype mostly in the bone marrow. Although we could do it in the peripheral blood, it's typically not done. And I think we would do it. So a bone marrow is generally obtained only in patients who need treatment, as opposed to patients with a new diagnosis. So, that is a little bit different compared to what this patient has, which is advanced stage disease, and so they're likely to need therapy. So I think a stimulated karyotype is probably a reasonable thing to do. And I think we've started to define this as high complexity versus low complexity. And so high is more than 5, and between 3 and 5 is low complexity, and then no or no complexity or non-complex would be less than 3 abnormalities. But you're right, I think these data keep evolving, they keep changing the definitions. But I do think that more than 3 would be considered as standard sort of abnormal in most places.
What do you think?
Yeah, I think that at least the previous standard has been, you can do that on peripheral blood with the CPG stimulated karyotyping, and 3 or more unrelated cytogenetic abnormalities defined as complex.
Okay. So this patient does have a bone marrow biopsy. There's diffuse infiltration by CLL, and that's the likely explanation for why the patient has the cytopenias that they do. So a decision was made to start ibrutinib, and we discussed this already. The dose was 420 milligrams once daily in a continuous fashion with the intent to treat until progression or an adverse event. Unfortunately, this patient did have some adverse events that need to be considered. They developed grade 3 neutropenia relatively early in the course of therapy, which ultimately resolved with management, and that management was a dose interruption, and then the patient was started at a lower dose. And I also should mention that this patient developed grade 3 arthralgias, which is a relatively common toxicity associated with BTK inhibitors. It's been best described in patients who are treated with ibrutinib, and for that reason as well, the patient had a dose reduction and they resolved to grade 2 or grade 1, so ibrutinib was better tolerated.